Okay, good afternoon. My name is Steven Aguilar Miranda. My topic is application of high sensitivity troponin in suspected myocardial infarction. Continue. Introduction: data ranging high sensitivity troponin contractions in patients presenting to the emergency department with symptoms suggestive of myocardial infarction may be useful in determining the probability of myocardial infarction and success 30-day outcomes. Continue a video.
This is a really important meeting for UT Southwestern. We have presence throughout the meeting. We've got multiple members of the cardiology faculty that are on the planning committee. The AHA president is from UT Southwestern and the CEO of our university hospitals. What I'll be talking about in my lecture is a new blood test for diagnosing heart attacks and the application of that in the U.S. marketplace. This is a test that we've been working on as researchers at UT Southwestern for a long time and has actually been implemented in Europe. But it's about to be implemented at our hospitals at UT Southwestern and subsequently in other places in the rest of the United States. As many of you know, we have over 6 million emergency room visits per year in the United States for chest pain, and EDs are already overcrowded, and so there's tremendous pressure to try to unclog emergency rooms and deal with chest pain more quickly. We're already measuring troponins for myocardial infarction, and the new test is both more sensitive so it can detect levels that we couldn't previously detect and more precise so that we can evaluate very small changes over very short time periods. And that low level detection range and that precision allow us to exclude MI very quickly. In the current state, it takes 3, 6, 9 hours to rule out MI. With our new protocol, we can rule out MI in over half of patients in an hour. And we think that's going to have dramatic implications for how fast and effectively we can move people through our emergency rooms and disposition them safely without using excess resources.
Okay, continue. Application in medicine. The development of high sensitivity troponin is allowed for the identification of small-scale myocardial injuries, thus improving the detection of even small myocardial infarction 5-6 hours. Owing to the higher analytic sensitivity of this easy clinical management, decisions have become more challenging. Consequently, algorithms have been developed to target patients with suspected myocardial infarction effectively. Pros fears with the sensitivity troponin that it is difficult to differentiate between bad patients we present to the emergency department with acute myocardial infarction and those who have other cause of myocardial injury. Cons: a second attempt is narrowly assessed than the initial blood sample for troponin storage should be obtained immediately on presentation. The appropriate timing of obtaining the second blood sample is a matter of debate, and recommendations vary between 1 hour and 6 hours. Continue a video.
Hello, I'm Joseph Albert, Editor-in-Chief of the American Journal of Medicine, and I'm here today to call your attention to what I think is a really interesting article. It's by Sandoval et al., and it's from one of the most scientifically advanced centers in the study of troponin as a marker for myocardial ischemia in Minneapolis at the University of Minnesota. The senior author is Frederick Apple, who's one of the best-known troponin research investigators in the world. This article confirms what has been talked about from Europe for a while, and that is when patients come to the emergency room with chest discomfort, a single negative troponin combined with a normal electrocardiogram rules out ischemic heart disease in just about 100% of patients, just slightly less. So this is going to be a real boon once the high sensitivity troponin test spread in the US. The first one has been approved. It's a troponin T test by Roche. The test used by Apple's group was a troponin I test, but I'm expecting a number of tests using the I troponin will be approved by the FDA in the very near future, and then hospitals are going to have to figure out how to use them. But once that dust settles, this is going to be a very, very useful test to help us send a number of patients home without admitting them to the coronary care unit. So we're going to match the rest of the world. Europe has been using these high-sensitivity troponins for many, many years, and now the United States is going to have the same test. Thanks so much for reading the American Journal of Medicine. Please take a look at our blog and our website. We're also available on Twitter and Facebook for those of you that prefer following us that way.
In conclusion, a risk assessment tool which with the both integrate the high sensitivity troponin U and troponin T concentration at measuring the permanent presentation is dynamic change during serial sampling, and the time between the outlining of symptoms was used to estimate the probability of myocardial infarction on emerging the permanent presentation and 30-day outcomes. Continue a video.
Clinic in Rochester, Minnesota. Here at ACC 2018 for Fits on the Go video blog, I have the distinct pleasure of talking with Dr. Alan Jaffe. He's professor of cardiology at Mayo Clinic and professor of laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota. Thank you for joining us today, Dr. Jaffe.
It's my pleasure.
So there's been a hot topic here at ACC this year surrounding high sensitivity troponin, and you've really been staple in production of this biomarker. Can you give us a little bit of information about high sensitivity troponin and what you've been discussing here at ACC 2018?
Well, high sensitivity troponin has been available throughout the rest of the world since 2010. So there's 8 years of experience, and we can use that experience in making sure that things go smoothly here. In point of fact, if we educate properly, this should end up allowing us to discharge patients from the emergency room who don't have an acute coronary syndrome much more rapidly, and be more secure in admitting those people who do have an acute coronary syndrome. But there's going to need to be some education, because there are going to be far more modest elevations in patients who have a variety of other diseases, both cardiovascular disease and non-cardiovascular disease, because they represent one of two things: either structural heart disease that is underlying, or a stress response, supply-demand imbalance. And in that circumstance, if all those people are considered MIs, quote unquote, then you're going to swamp the system, and those patients aren't going to get care for their primary illnesses, which may be heart failure or arrhythmias, or maybe a non-cardiac diagnosis. So we need to be careful to make sure that we don't conflate an elevated troponin with acute ischemic heart disease. It's never been the case that it was, but unfortunately with the less sensitive assays, the higher troponins are associated with ischemic heart disease. So there were more of the elevations that really were associated with ischemic heart disease, and we now need to change that paradigm. And there are a variety of protocols that have been suggested. I've suggested one that we're going to implement at Mayo that I wrote up for the American Journal of Medicine in December of 2017 about how to think about this, because there's some pitfalls in them. And one of the pitfalls is trying to do things with what I call tight windows, small changes. And small changes are beyond the ability of some of the assays to detect. And in addition, we all have physiologic responses, so that we all can have some modest changes, and that can become a problem if one doesn't have one's thinking hat on.
And I know you've really dedicated your career to work in the...
Okay, thank you. Finished video.